Welcome. I'm delighted to welcome all of you to the session 6 of our webinar series on advances in thalassemia care, which is jointly organized by Thalassemia International Federation, Thalassemia India, and Postgraduate Institute of Child Health, Noida, in association with ECHO, who is our partner in organizing and implementing these webinars. So for today's session, I welcome you all. Today's session focuses on a very important topic on cardiac morbidity in thalassemia, how to prevent it and how to treat it. And we are very happy to see that there are pediatricians, hematologists, researchers, and patient group members who have joined in from across India, as well as few from international, from other countries as well. Thank you for your continued commitment for improving thalassemia care. So to begin the session, I would like to invite our medical advisor from Thalassemia International Federation, Dr. Michael Aggarwal, for his opening remarks. Over to you, Dr.
Okay, thank you very much. First of all, I have to apologize for the absence of Dr. Androula Eleftheriou, who has been caught in another meeting. So I'm speaking on her behalf. From the International Thalassemia Federation, first of all, I would like, along with Dr. Nita, to welcome everybody. Heart disease in thalassemia has been really, over the years, the major cause of death and one of the major causes of morbidity in thalassemia. It is, as patient treatment improves, it becomes less of a lethal disorder, but still an extremely important cause of morbidity. And of course, this will affect the quality of life. So I welcome the emphasis that is being given today to heart disease. And I'm sure we're going to hear your experiences on this important complication. Thank you.
Thank you, Dr. Michael. As you said, rightly said, by after the age of like 15 to 20 years, this is one of the major morbidities that we encounter in thalassemia care in our country, especially because the standards of care are not similar across the country, and many centers are able to only transfuse and chelate very poorly, as a result of which the morbidity just goes on increasing after the first decade of life. So for the context setting of today's session, I now invite Mrs. Shobha Tuli, founding secretary of Thalassemia India and on the executive board of Thalassemia International Federation. She's been an unwavering voice for thalassemia community in our country, and she's been championing patient rights. She brings together doctors, patients, and all stakeholders together, including the ministry officials, so that there is good treatment which is available across the country for our patients. Ma'am, may I request you to discuss the context of today's topic?
So first of all, thank you, Dr. Nita, for your kind words. And I think what Dr. Michael has said and what you have said in your initial remarks is what I was going to say. But still, I will repeat it. First of all, I would like to thank all the experts who are here for their time and for joining us. And we all know even the patients community. So whatever I'm going to say here is on behalf of the patients community, their concerns. And I'm very sure that all these issues will be covered in the presentations by our experts. So we all know that how important is the cardiac care, and this has been the single, because few years back, rather I would say about 15-20 years back, it used to be one of the single leading cause of mortality in transfusion, thalassemia dependent transfusion patients, but is now significantly declining in patient populations because they have access to the good healthcare, which includes, of course, all the facilities and the diagnostic investigations and the chelation therapy. And you will also agree with me that when the patients have the regular blood transfusion, to optimize pre-transfusion hemoglobin and adequate chelation from a young age, which is mainly not followed by most of the patients, are the basic principles to prevent cardiac issues. We are all aware about it. However, there are a few concerns which I would like to mention it here. Number one is that I have seen, that's my personal experience after having so many years spent in the care of thalassemia patients, is that the lifestyle, which is very, very important for this thalassemia management and care, is often ignored, even in the developing world. And the early detection of cardiac complications is also sometimes not being taken care of. Of course, if they don't have the facilities and all that, whether it is the availability of the RM chelators or whether it is the diagnostic facilities, that is also not been looked very seriously, even in the countries developed worlds. But what to say about the about places where they do not have access to such facilities? So in the absence of such facilities, what should be the other options left with our patients? And sometimes I have seen when the patients have the cardiac issues, they do not know that which RM chelators are to be taken and which are not to be taken. So that's something very important, needs to be discussed and brought in front of our patients' community. And my last point, which I want to raise, is that the patients who are living in the developing countries and also in sometimes the disturbed areas where they do not have access to the proper care and the treatment and the management, and they do not have access to the diagnostic facilities, should we leave them to their destiny, or is there any suggestions by our experts that what you can guide them, and how, what would be the instructions given for such kind of patients? I'm very sure that all these concerns which I have raised on behalf of the patient communities will be addressed in the pursuing presentations. Thank you very much, and over to Dr. Nita, please.
Thank you, ma'am. So now coming to a brief overview of the program. So the first speaker for today is Professor Dimitrios Farmakis. No, we don't need an introduction for Dr. Dimitrios. He's a professor of cardiology at the National and Kapodistrian University of Athens, Greece. And he's an expert in managing thalassemia, especially the cardiac complications of thalassemia. He's globally respected in management of thalassemic cardiomyopathies as well as cardiac manifestations, and a lot of guidelines and articles that we have read are authored by him. We are fortunate to have two pediatric cardiologists who are joining in from our India today, and both have been actively involved in the care of children with thalassemia. First, we have Dr. Neeraj Aggarwal. He's Director of Pediatric Cardiology at Gangaram Hospital, New Delhi, and he joins us as a panelist for the scientific the panel discussion that will follow Professor Dimitrios' talk. Dr. Neeraj is widely recognized for his expertise in congenital and acquired cardiac conditions in children, especially in North India. And our final speaker for the evening is Dr. Anuj Sharma. He is the Assistant Professor in Pediatric Cardiology at Postgraduate Institute of Child Health, Noida. He has been actively involved in our Thalassemia Treatment Center, involved in cardiac monitoring for thalassemia patients. So we are very fortunate to have him join today because he brings in a practical perspective to today's discussion. And finally, the young Turk, Dr. Sudipto Bhattacharya, will be discussing the cases today. So he is the new generation of training to be a consultant in pediatric hemato-oncology in our team. So he has selected 3 cases for us today, non-transfusion as well as transfusion-dependent thalassemia, which will focus on real-life dilemmas, decision points, and management challenges. So I hope we can cover most of the issues that have been brought out by you, Mrs. Tully, especially lifestyle issues and how to modulate lifestyle activity, exercise around thalassemia care. And so for the first talk, I would like to request Professor Dimitrios Farmakis to speak on cardiac morbidity in thalassemia, prevention and management. Over to you, Dr. Farmakis.
Thank you, Dr. Nita. Thank you, Dr. Nita, for the kind introduction. I hope you all can hear me. Good evening to India, good afternoon to Europe, and good morning, perhaps, to other parts of the world. So thank you very much for this invitation. Actually, I'm very glad to be joining this ECHO webinar series. I think that ECHO is an excellent educational platform that really promotes education in the field of globinopathies. And I think that it may serve as a blueprint for others that want to develop this kind of online educational events and initiatives. And you know that in TIFF, we value very much all the educational initiatives. So let me share my screen for my presentation. I hope it works. Okay, I hope you can see my presentation, right?
Yes.
Okay.
Yep.
So I have been asked to talk about cardiomorbidity in thalassemia, which is actually one of my favorite topics, and I have been active in this field for 3 decades now. So I'm glad to present my disclosures, and I have divided my presentation into 3 parts. The first part on the past and the present of heart disease and thalassemia, the second on new challenges, and the third one on new tricks that we now have in the field of cardiology. So I will start about epidemiology. As previously said by Dr. Agastinotis, by Mrs. Tully, heart disease has been the leading cause of mortality in patients with thalassemia across the years. But there has been a considerable progress in the management of thalassemia, as you all know, and this has been reflected in the survival rates that actually now tend to reach that of the normal population, but not everywhere in regions, in places where patients have actually access to quality care for thalassemia. And this is also reflected by the evolution of heart disease. So this comes from a Greek registry of hemoglobinopathies. You can see that there is a significant decline in the overall mortality rates in the left panel of the picture. And this is exactly in parallel with this similar decline in the rate of cardiac deaths. So the reduction of mortality actually follows the reduction of cardiac disease, which has been the leading cause of mortality in these populations. And this does not concern only Greece, but other places as well. This comes from Italy, again, a decline in mortality, a dramatic improvement in survival, at the same time, a rapid decline of heart disease over the previous decades. And this comes from a cyber cohort of patients where you can see that heart disease nowadays in contemporary cohorts of well-treated patients, heart disease now the prevalence is below 10%. It was 8.8% in this cohort of cyber patients with thalassemia. So this is the first fact of this presentation that I want to stress, that there is decline in cardiac complications and mortality that has led to a similar decline in the total mortality of the disease, but not everywhere where patients have access to proper care. So what are the forms of heart disease? This comes from a meta-analysis of different studies showing the main forms of heart disease patients with thalassemia that include heart failure, pulmonary hypertension, and arrhythmias. And this is a diagram of the pathophysiology of heart disease in patients with thalassemia. You can see that it all starts with the hemoglobinopathy itself, with the hemoglobin defect that leads to ineffective erythropoiesis and then to hemolysis, with anemia, the need of transfusions, which in turn lead to iron overload. And these factors actually drive the pathophysiology of heart disease in these patients. The phone rings because I'm in my office. Sorry about this. I will disconnect it just for a moment. Sorry for this. So, and you can see that these main drivers of pathophysiology of heart disease and thalassemia are actually driven and can actually be addressed by the disease-specific therapy, which is transfusions for anemia, iron chelation for iron overload, the multidisciplinary care for the different complications that also contribute to heart disease. So the disease-specific therapy is actually the prevention and the cure of heart disease in patients with thalassemia. With evolution of care, we have been dramatic improvement in the management of patients that, as I said earlier, it has been reflected at the progress of survival in these patients. And this is actually reflected also by the forms of heart disease in these patients. So before the introduction of regular blood transfusions, before the 70s, the main cause of death of these patients was actually high output heart failure because of severe anemia. And this actually happened in the second or usually in the second or sometimes the third decade of life. So then after the introduction of regular blood transfusions, the problem of iron overload came up. And this led again to heart failure, again to cardiac disease. But at this time, it was not the anemia-related high output failure, but the iron overload induced cardiomyopathy. Still a lot of high cardiac mortality. But with the introduction of proper iron chelation therapy, actually, and coupled with the regular blood transfusions, we had actually no or minimal heart disease. This is where we are now in populations where there is access to proper disease-specific care. What about pulmonary hypertension? This has been the main problem in non-transfusion dependent thalassemia, one of the leading cause actually of heart failure and mortality in these patients, much more than in thalassemia major patients. And this has also been improved over the years because the treatment of patients with non-transfusion dependent thalassemia has been improved. And with reduction of blood transfusions, even in this population, with the increase in the rate of blood transfusion, there has been a drop in heart failure and in pulmonary hypertension, again, as a result of the better treatment of the main disease, which is actually thalassemia. So the second fact I want to stress is that the forms of cardiac complications has evolved in parallel to the evolution of thalassemia therapy. So coming to the next part of my presentation, actually, there are new challenges that we have to face nowadays. This comes from a single thalassemia center in Nicosia in Cyprus, where you can see the evolution of the age of the patients. And you can see that as time goes by, there is an increase in the median age of the population from mid-20s, many years before, till the early 50s nowadays. So there has been an aging of the population, which is actually a big success of the optimal treatment of the disease itself. But this leads to another problem, which is the aging-related complications. And the cardiovascular system is particularly affected by age-related complications, including atherosclerosis, arterial hypertension, atrial fibrillation, aortic stenosis, and heart failure with preserved ejection fraction, all very age-related problems in cardiovascular disease. And of course, first of all, it was stressed earlier, the lifestyle risk factors. Our patients still smoke a lot. They may not have the level of physical activity they should have. They may have excessive alcohol consumption, unhealthy diet, and along with the poor management of other comorbidities. But the lifestyle factors are becoming increasingly important in this population of patients thalassemia, particularly because of aging. And we have to put a lot of emphasis on the modification of lifestyle factors. Then we have atrial fibrillation. It's much more frequent in patients with thalassemia, driven by many mechanisms, as you see in this slide. But the elephant in the room is actually, again, aging. And of course, atrial fibrillation is not just an anemia. It may lead to several cardiovascular complications. And first of all, it increases the risk of stroke. And managing, of course, atrial fibrillation with anticoagulants may be actually challenging because thalassemia itself may be a hypercoagulable state, particularly the non-transfused patients with thalassemia intermediate or non-transfusion dependent thalassemia, particularly the presence of splenectomy. But at the same time, these very patients may actually be prone to an increased risk of hemorrhage. Then we have new therapies like the hematopoietic stem cell transplantation that also has cardiovascular complications, and there are early toxicities and late toxicities associated with hematopoietic stem cell transplantation that we should care about. So the third fact I want to stress is that the thalassemia population is aging because of the good therapy, and that aging now poses new forms of cardiovascular diseases along with new therapies and thus new challenges. Coming to the next part about new tricks that we have nowadays, of course, you know that cardiovascular monitoring has been very important in the management of patients with thalassemia and still is. Even in patients with very good treatment, we need an annual cardiac examination with physical examination, ECG, echo, and then in periodic intervals, we need the cardiac MRI along with liver MRI for the T2 star for the evaluation of iron overload. And this is done even better when there is a monitoring, a network of care that coordinates the monitoring and management of patients, and this comes from the MIOT or MIOT network in Italy, where the guidance of treatment and monitoring of patients by a network actually promotes the better management and improves the outcomes of patients. We have new imaging techniques now that complement the good old echo that all our patients have every year. We have the myocardial strain analysis with complementary information associated with iron overload, associated with the risk of atrial fibrillation that can provide supplementary information. We, of course, have the T2 star for the cardiac MRI and the liver MRI for the evaluation of cardiac iron and liver iron, but we have additional modalities with the MRI, which is an excellent way of imaging the heart, showing the structure, the function, the quality and the characterization of the myocardial tissue, and additional information like the extracellular volume that are also related to the degree and the risk of cardiac complications. And of course, we have now enhancement of our diagnostic modalities with artificial intelligence that may actually predict future development of heart disease like atrial fibrillation. In this case, with a simple ECG, AI may predict the development of atrial fibrillation up to 10 years before it happens. And of course, the cardiovascular management that actually is based on the management of the disease itself, of disease-specific therapy, the treatment of anemia, the treatment of iron overload, the multidisciplinary approach, and then, of course, the specific management of cardiac complications if they arise. We have new therapies for heart failure. We have the introduction of new drugs in the management of heart failure, the so-called sodium glucose contrasporter 2 inhibitors, and anti-diabetic agents with impressive effects across the spectrum of heart failure. So this is the treatment now for all forms of heart failure, and also it prevents the development of heart disease and heart failure patients with diabetes and CKD. And every patient with type 2 diabetes, CKD, or heart failure should take this medication. We have new cardiac interventions. We can have this transcatheter aortic valve replacement without cutting open the chest, or the transcatheter repair of the mitral valve, or the treatment of atrial fibrillation, actually, with these devices, with this catheterization, without performing any operation to the patient, just percutaneously. And we have the new developments, new domains of cardiology, like cardio-oncology, which actually deals with the complication of therapies that are also relevant to patients with thalassemia, like the hematopoietic stem cell transplantation and the gene therapies that are now appearing in the field. And of course, new thalassemia drugs like luspatercept that decrease the need of transfusion therapy and thus the iron load of the patients. So my final fact is that the recent diagnostic and therapeutic advances may actually improve further the thalassemia outcomes. So some key take-home messages: heart disease is preventable with proper thalassemia-specific care, and actually the improvement of care has led to a decline in heart disease that has in turn led to a decline in overall mortality of the disease. Heart disease is treatable. Actually, iron cardiomyopathy is one of the few truly reversible cardiomyopathies with proper therapy, with iron chelation therapy, of course, when it is timely started. So early cognition is very important, and this leads us to the need for regular cardiovascular monitoring along the other components of the multidisciplinary care, and of course, the need of collaboration and networking. But what is the global situation of thalassemia right now? Unfortunately, more than 60% of patients do not have really access to quality care. Less than 12% of those transfusion-dependent cases actually are regularly transfused, and less than 40% of patients, of regular transfused patients, actually receive proper iron chelation therapy. So we have to do much more for the access of patients to proper care. And this comes the role of Thalassemia International Federation, this global umbrella organization that you all know and that you all very nicely collaborate with in defining the best practices through our series of guideline recommendations, in promoting education through conferences, webinars, publications, e-courses for physicians, for healthcare professionals, for patients, through different apps like the Thalia app, and of course through Tiflix that you all probably know, and then also in promoting and supporting collaboration and networking through regional networks, including the Indian subcontinent network in your country. So with this, I thank you for your attention.
Thank you, Dr. Farmakis. I think before we go to the panel discussion, we have a couple of questions in the chat box. So maybe we can discuss it with you before we start the panel discussion.
Yes.
Any multivitamins we can take to reduce or minimize cardiac issues?
Yeah, of course. Patients have been taking vitamins for many reasons, for iron overload and so on. There are no specific vitamin preparations that address or prevent cardiovascular disease. It is rather the lifestyle issues that prevent cardiac disease, like abstinence from smoking, good physical activity, healthy diet, and of course, adherence to good disease-specific therapy and multidisciplinary care. These are the important components to prevent heart disease, and not just taking some multivitamin preparations. We cannot hear you, Nita.
Ma'am, you're muted, sorry.
Sorry. What is the pathophysiology of restrictive heart disease that is often seen in our setting? And how is it best managed with other than chelation?
Yeah, of course. Restrictive physiology may come from different pathogenetic drivers, and particularly patients with thalassemia. The main reason for restrictive cardiomyopathy is actually iron overload, and myocardial iron overload actually may lead to restrictive cardiomyopathy, but also this may progress into dilated cardiomyopathy. And some other patients develop just restrictive cardiomyopathy till the final stages of the disease. Some others tend to develop dilated cardiomyopathy, and this has actually a genetic component. Now, the best thing to address this restrictive cardiomyopathy is actually iron overload. To prevent this, but also to treat this. And of course, even when there is severe heart failure because of severe overload, still we can do a lot to treat our patients. There are many, and in many cases, if the damage of the heart is not very severe, this may be reversible with intensified iron chelation therapy that may need to be actually intravenous when there is acute heart failure or severe heart failure, and then very, very intensified and combination chelation therapy to treat the so-called rescue chelation therapy to treat cardiac disease. And of course, the supportive treatment with the patient may need different cardioactive medications that are actually not very effective unless iron overload are properly addressed. So again, iron chelation.
Yeah, there's nothing great other than iron chelation. So
exactly.
So and the last question is SGLT group of drugs. How safe is it to be given when it is given with chelators? That's first question. And what is the lower limit of age at which SGLT inhibitors can be safely given to patients? And does it worsen any endocrine pancreatic function?
Yeah, good questions. Now, SGLT2 should be prescribed to any patient, regardless of thalassemia or not, with heart failure, chronic kidney disease, and type 2 diabetes. So every patient suffering from these three entities should take SGLT2 inhibitors. SGLT2 inhibitors are very, very safe drugs. Sometimes there are very rare complications like local genitalia infections, but they're very, very simple complications, and they can be very, very nicely prevented if there is proper care, keeping the area dry after urination, and this happens usually to patients with type 2 diabetes. And so every patient should take SGLT2 inhibitors if he or she has diabetes, heart failure, or CKD with an eGFR below 30 or below 60, or with significant albuminuria. Now, there are no major safety issues. I'm not sure about trials in children because I'm not a pediatric cardiologist, but I know that these drugs are safe in adult patients. Perhaps our pediatric cardiologist can address this.
Yeah, I think we'll take this up again when we have the panel discussion. So we'll discuss the rest of the question along with the panel. Now I would request Dr. Sudipto to kindly present the cases, and I'll just share it from my side. So we have a set of three cases for the panel, and questions directed to the cardiologists who are joined us today. So over to you, Dr. Sudipto.
Good evening, ma'am, and good evening, Professor Farmakis, and all delegates who have joined. And I would like to thank Nita ma'am for giving me this opportunity to present these cases. So the first case is a case of transfusion-dependent thalassemia with severe cardiac iron overload. This child, 15 years of age, came to us and diagnosed as beta thalassemia major. He was a transfusion-dependent phenotype on regular transfusion. Was initially treated outside in a local center, and from 2023 was shifted to our center. So previously maintained at 6 to 8 gram per deciliter his hemoglobin, and on examination he was having short stature with enlarged spleen. And 2023 his ferritin was 1342 nanogram per ml. He was on deferasirox, and we had treatment modifications were also done, and we had increased his transfusion requirement to target a pre-transfusion hemoglobin of 9 to 10 gram per deciliter and escalated the chelation. So we had done a MRI T2 star in October 2024, last year. So here it was showed that T2 star MS was 7.48, which was indicative of severe myocardial iron overload. and the liver T2 star was 1.0 ms. So that was also having a severe hepatic iron overload. So these were the ferritin trend over time. As we can see that this ferritin from 1400, so was steadily climbing, but and had climbed up to 2800. But we had also increased the escalation accordingly. Chelation accordingly. So following the MRI T2 star, chelation was escalated, and we had added deferasilox and deferiprone. We had done an echocardiographic examination, which showed normal left ventricular ejection fraction. He had tolerated both the chelators well. However, it was stopped briefly for 2 times because of low ANC, and we identified a matched donor in the family for hematopoietic stem cell transplant. He was initiated on IV desferoxamine in January 2025, and he's presently on hydroxyurea and azathioprine for pre-transplant preparations. So this figure, as it is steadily improved from 7.48 to 10.89 and 12.3, and indicating that the myocardial iron overload had decreased. However, the liver T2 star was roundabout same and indicated severe hepatic iron overload. So these are the growth monitoring. So his growth was persistently below the third centile, but as we can see that little bit crept up in the later stages. So I would like to hand over the to Nita ma'am for the questions in the panel discussion.
Yes, thank you, Dr. Sudipta. So now we'll start from the basics. This has been briefly mentioned by Dr. Farmakis. What are the recommendations as per TIF guidelines? What are the recommendations for cardiac evaluation in patients with transfusion-dependent thalassemia? Dr. Farmakis?
Yes, cardiac evaluation. We need, as I said in my presentation, an annual cardiac check with physical examination, history taking, physical examination, ECG, and echo. And then we need also the cardiac T2 star, which is part of the also the evaluation, the MRI evaluation of liver iron. Usually we do it together in Greece. In other places they are done separately. We need this in periodic intervals to see what is going on with cardiac iron transfusion-dependent patients. So annual physical examination, ECG, echo, and then the frequency of T2 star imaging for the cardiac MRI depends actually on the level of iron overload that the patient has. Typically, it is recommended every 2 years. Sometimes we may not need to do it every 2 years if the patient has very stable heart disease and no additional problems with severe iron overload and so on.
Thank you. And just to be clear, this is after 10 years that you're recommending, right? So I think he's on a call. We'll come back to him for that question. So Dr. Anuj, in an outpatient setting, when we are seeing thalassemia patients who are just coming for a regular visit just to titrate chelation, or when we are seeing in the thalassemia treatment centers, what are the symptoms that we should be asking that is from a cardiac standpoint?
Okay. Good evening, ma'am, and good evening, everyone. And thank you, Nita ma'am and ECO webinar series to giving me this opportunity to share my views. So coming to the question, so in a patient with thalassemia with cardiac involvement and who is visiting us in the OPD, we should the symptom which we should see are symptoms of heart failure or arrhythmias or pulmonary hypertension, which are the major cardiac morbidities in these patients. When the patient has heart failure, they have symptoms like easy fatigability, exertional dyspnea, orthopnea, swelling of the feet, abdominal swelling, and decreased exercise tolerance. And the when they have arrhythmias, then they have the symptoms of palpitations, dizziness, lightheadedness, symptoms of syncope and pre-syncope. And the symptoms of pulmonary hypertension generally overlaps these symptoms only, like syncope, exertional dyspnea. So these are symptoms we should look for in when the patient is presenting to us in the OPD.
A regular outpatient. Thank you, Dr. Anuj.
Yeah.
Now, in your practice, Dr. Nita,
Sorry, Dr. Nita, may I ask a question?
Yes, sure.
The patient that was described is actually being primed for a bone marrow transplant. And I was wondering, what about the cardiac function? What's the ejection fraction? What should we be aiming at to make it safe, if you like, to ensure safety, if you like, for the transplant?
In this particular patient, since we are following up this child, he has a normal ejection fraction. Although his cardiac iron overload was bad earlier, now it is moderate iron overload. But his ejection fraction throughout during follow-up has remained normal. So we can go to the next question, Dr. Neeraj. So what are the investigations that you recommend? So we had a brief overview from Dr. Farmakis regarding TIF guidelines. In your practice, what all are you doing for patients who are coming? Symptomatic as well as asymptomatic patients.
Yes, so ma'am, as Dr. Farmakis has already covered this part, in India also, we follow the standard protocols. Like I would like to do ECG and echo starting at 10 years of age. That is the primary guidelines in our system, where we follow this strictly. ECG and echo annually starting at 10 years. Now, the question arises about MRI. Some centers don't have MRI availability, but T2 star MRI, we want to do a T2 star MRI at baseline at 10 years of age. And then every 2 to 3 years, if things are normal. If they're abnormal, we do it earlier. So these are my guidelines. But, if your child is symptomatic earlier, suppose child is symptomatic 8 years, we might like to do ECG and MRI, which is echo and ECG and echo. But I have never seen a patient who's presenting at 8 years of life with some symptoms of cardiac. So I'm yet to see a patient who is symptomatic at 8 years. So starting at 10 years, we'll do the precautionary checks. And if they're abnormal, we do the change in policy depending on abnormality. Like if MRI is abnormal, we do it earlier. Otherwise, as Dr. Farmakis says, every 2 to 3 years, we do it.
Ma'am, you are muted.
In this case as well, Dr. Farmakis, there is a discordant ferritin and MRI. So we all know that ferritin is not a great marker for iron overload. So in practice, what should we use? What are the trends that many centers would not have access to MRI per se? So many a times you are dependent only on ferritins. And in an NTDT setting, we always try to get an MR done and try to get an evaluation done earlier. But in a transfusion-dependent settings, what should we use to guide our chelation decisions?
That's a very good question. Actually, for the cardiac iron, ferritin is not a good marker, as you know. It is not very good. There is no relationship between actually serum ferritin levels and cardiac iron the way that we measure it with cardiac T2 star. So we need cardiac T2 star to evaluate cardiac iron overload. Now, when we do not have cardiac iron overload, we need to follow the trends actually in serum ferritin if this is only what we have. And actually, when there is a decline in serum ferritin, there is first the clearance from iron from the liver, and then the clearance of iron from the heart will follow next. So the heart gets not very easily iron in, and similarly gets not very easily iron out. So it needs more time than liver, both to be saturated with iron and also to be relieved by iron. So we may have the, let's say, the strange thing to have a very good trend in lowering serum ferritin, And at the same time, still the cardiac MRI can show us a very low T2 star value, which means a big iron overload in the heart, because clearing the heart from iron takes time.
Yeah, so the typical scenario that we see is children who are transfused at a lower threshold, and so typically they would receive much lesser blood than that they should actually receive, and they monitored only on ferritin. So by the time that we get to see them at like 14, 15 years of age, they already have significant iron overload, and ferritins don't really match that symptom.
Exactly.
Yes. So, Dr. Anuj, what all do you look for in an ECG and echo? Many times we don't have a pediatric cardiologist, let alone a cardiology access for such children. So, when a thalassemia treating physician is ordering this, what all should they be looking for in the reports?
So in echo, we should look for the systolic and diastolic function, and there are some parameters for diastolic dysfunction and systolic dysfunction which can be affected early due to iron overload. And in diastolic dysfunction, for diastolic function, the sum of the parameter which can be looked into, like E by A velocities ratios, E by E prime ratio, and reduced E prime velocities, and left atrial enlargement, left atrial volume index can be also be looked into. And while looking for the systolic function, then global longitudinal strain and the left ventricular ejection fraction can be looked into. And coming to the ECG, on ECG we look for the parameter which can be deranged, are QTC interval or QT dispersion can be there, or there can be ST non-specific ST segment depressions, and there can be atrial or ventricular ectopics, or there can be some arrhythmias as well. So all these parameters should be looked into. You are not.
I think they should. You would agree that they should be actually carefully seen by a cardiologist who is experienced in handling thalassemia, which is
Yes.
probably not available for most of our patients all the time. So
Dr.
now,
Nita, I would add
yes,
one thing.
Dr. Neeraj, yes.
Actually, we don't do strain a lot of times.
Mm.
And I personally, my opinion is strain will be useful in thalassemic patients to detect early disease. So, in a routine practice, Dr. Farmakis can agree with us that, routine practice should ask for a strain from cardiologist and then start involving that part that strain has to be covered. A lot of people don't do strain. It's an easy job, actually. Strain not a very big job. A lot of things are automated and it takes 3 minutes more to do strain only. But we have to start asking for the strain values in thalassemic patients.
Dr. Farmakis, any comments?
Yes, of course, it is a complementary information that we may get out of it, and it's easy to implement actually. And actually, the trend in the global longitudinal strain, perhaps in other strain parameters, actually may act as may serve as an early marker of upcoming cardiac disease. So it's an early marker and can be easily incorporated in our clinical practice.
Thank you. So now when you have an MRI report which says that MRI evidence of severe cardiac iron overload, if there is no cardiac dysfunction which can be demonstrated on an echo, are there any drugs that can help, any cardiac medicine? Of course, we'll escalate chelation. So Dr. Neeraj, would you recommend any cardiac medications in this scenario without any evidence of cardiac dysfunction?
So, there are 2 points about this cardiac medications. One is, if you are talking about chronic failure, like this case, we're talking about chronic failure. One thing, of course, we have to ensure the compliance with chelation, which I feel in my field is lacking. A lot of patients are coming up with us with chronic failure because of chelation. Now, if you say my heart failure is preserved, but you have to talk about diastolic failure then. If your diastolic failure, you add SGLT2 inhibitors as per ESC guidelines 2023. I think SGLT2 inhibitors will be helpful if you have preserved ejection fraction, but you have diastolic failure. Now, diuretics can be used as well. But if you have a heart failure with reduced ejection fraction, then all spectrum of drugs can be used to manage heart failure, where we use lot of drugs where you have cardiac dysfunction, like newer drugs like Vimada group of drugs where you have sacubitril valsartan, which we use, beta blockers, and SGLT2 inhibitors. These three drugs we normally use with or without dysfunction. SGLT2 we want to use in every case if you are demonstrated diastolic dysfunction, systolic dysfunction. Now this may be a controversial topic to use SGLT2 inhibitors in without cardiac dysfunction, but with diastolic dysfunction, I'm saying. If you don't have any dysfunction, diastolic, systolic, I'm not adding any cardiac medication, that group. So with iron overload, I would go for chelation only. With cardiac dysfunction, with systolic dysfunction, I would add all the drugs, including Vimada, SGLT2 inhibitors, and beta blockers. Without cardiac dysfunction, I would not add any drug actually. I would intensify the chelation. Let's take opinion from other people also about this part.
I think Dr. Anuj would agree because we had a similar patient recently. We were asking him whether we can start anything. Yes, Dr. Anuj?
Yes, madam. Actually, when there is no cardiac dysfunction, so I don't think there is any need for adding any drug.
But we're talking about both systolic and diastolic dysfunction.
Yes,
both are not there.
Yes.
And Dr. Neeraj, regarding this HGH inhibitors, what is it is approved in pediatric practice, right?
So, beyond 10 years, data is there. 10 onward, data is there. The multiple studies beyond 10 years. And as we understand, less than 10 years, anyway, we are not bothered in thalassemia especially. So I think it's safe to use in all age groups to talk about thalassemia.
Okay. So most of these issues anyway come up after the first decade. So Dr. Farmakis, there is a lot of recent data on adding amlodipine along with chelation as to improve chelation efficacy, not as a cardiac drug actually. So what is your experience? Can we use it outside trials?
Yes, this is actually a very old story, the use of amlodipine to somehow complement iron chelation therapy, because as you know, iron gets into the heart through the L-type calcium channels, where the same channels targeted by amlodipine and other similar drugs, the so-called calcium channel blockers. So there are studies, older ones and more recent ones, showing that amlodipine may actually contribute to the prevention of iron overload in the heart. But the problem with that is that many patients cannot actually tolerate amlodipine because it drops the blood pressure. This is an antihypertensive drug. So if the patient actually tolerates it, up to 5 milligrams. This is a good, let's say, complement to iron chelation therapy. But if the patient has low blood pressure, it cannot actually tolerate amlodipine. This is the problem in using it.
So it can be used. That's what you're saying?
Dr. Farmakis,
can be used, but sometimes the patient cannot tolerate it.
Okay.
Dr. Farmakis, are we saying it can be used as a preventive modality? I'm not asking this question.
Yeah, it's mostly as a preventive modality, not as a treatment modality.
Because are you able to use it in your practice?
No, we don't use it because practically all our patients are very well chelated. So we don't need to add amlodipine. We have used it in the past in some patients, but not anymore.
Okay.
Yeah, but there are a lot of centers that are now using it as a chelating agent. And interestingly, it was not in the recent TIF guidelines. So that is why I wanted your opinion as to why.
Yeah, it's not a chelating agent. It is an agent that may actually somehow complement iron chelation therapy. But we cannot rely on this drug to prevent iron overload. It cannot be also tolerated by all patients. So still, proper iron chelation therapy is the key, and this is only a complement to that. Okay. Not just that to prevent iron overload. And of course, it is not good for treating iron overload in the heart.
Thank you. So,
Dr. Nita, I will have to go now to another meeting. Is this okay? Do you have any more questions for me?
Some more questions for you. We can finish it quickly if it's okay for another 10 minutes.
I cannot do it for that. I have already delayed the other presentation of 25 minutes. So
then it's fine. Thank you. Thank you.
Okay, thank you very much. Sorry for having to go early. Okay, I'll be glad to join the ECHO network and webinars again in the near future, and thank you for having me.
Thank you. Bye. So, Dr. Anuj, what are the other investigations that we should be doing in this scenario? Like patients with a cardiac dysfunction, should we be looking for thyroid function, calcium levels? What are the other tests that you advise routinely?
Yes, yes, madam. They are recommended, and we should look for other the metabolic and endocrine workup we should do, because iron overload is not the cardiac dysfunction is purely not because of iron overload only. There can be other endocrine and metabolic component which can be contributing to it. So thyroid functions, serum calcium level, vitamin D3 level, magnesium levels, blood sugars, and if in indicated cortisol level. So all these parameters should be looked into apart from the cardiac iron overload. So.
Thank you. Dr. Neeraj, feel free to add if there are any more suggestions from you.
Yeah, I understand. I think he's okay. I think what we are saying is, I would like to go for endocrine anomalies also, diabetes, sugar, because they are prone to have endocrine anomalies also, which can affect the cardiac dysfunction. Adrenal dysfunction also should be taken care. So we take care of adrenal dysfunction also. Look for steroid levels, cortisol levels. I think they should be monitored also, which can be useful in the cardiac system. Yes. Sometimes in acute stress situation, you can be helped by these cases. Yeah.
Thank you. So when do you evaluate with a Holter? If you have complaints of palpitation, or if you suspect, what are the indications for a Holter evaluation, especially in a thalassemia patient?
Yeah. So one strong guideline would be any adult who is 35 to 40, at least baseline Holter at once at 35 to 40 years of age should be done to find out the current what is happening in the atria. And then otherwise those cases who have high iron overload in the past or in the present. The most important part is past also. If it's currently star is more than 20, but in the past has been higher for a long time, they can still have iron overload in the atria. So that part has to be remembered. The past history is also important.
I think your signal is bad. If you can keep your video off, that will help, Dr. Neeraj.
Palpitation, older age groups, iron overload, ventricular dysfunction, syncope, and some ECG anomalies. If you have ECG anomalies, some PVF deformities, you should continue with that part.
Okay.
So that should be the guideline for Holter, not routine.
Okay. Thank you. And so now we come to the second case, Dr. Sudipto.
Yes, ma'am. So I would like to present the second case. Second case is a female 16-year-old child who was a case of transfusion-dependent thalassemia and came to us in June 2024 with palpitation and exertional dyspnea. She had, along with other conditions like iron overload and growth and nutritional delay and hepatitis C, which was treated. A transfusion and chelation history where she had this pre-transfusion hemoglobin cutoff of 7 to 8 gram per deciliter, and ferritin in June 2024 was 1650 nanogram per ml. We had evaluated her endocrine function. Her thyroid profile were normal. She had fasting hypertriglyceridemia with a normal fasting glucose. So on cardiology evaluation, we found that she was having a ejection fraction of 65%, but there was tricuspid regurgitation with pressure gradient of 45 millimeter mercury. She had pericardial effusion also. So at this point of time, she was started on treatment with sildenafil along with aldactone and furosemide. By December 2024, her tricuspid regurgitation pressure gradient had come down to 22 to 30, when ejection fraction was maintained at 65 to 69%. By 2025, our mean pulmonary arterial pressure was came down to 10 to 12 millimeter mercury, and hence sildenafil was discontinued as pulmonary hypertension got resolved. So we had modified the heart treatment. We had advised a regular transfusion at 15 to 20 days interval, targeted pre-transfusion hemoglobin of 9.5 to 10.5 gram per deciliter. Chelation, we had progressively increased as per requirement. Deferoxerox was around 40 mg per kg and her deferriprone was 75 mg per kg. And this was the ferritin trend. Suddenly there was a spike in the ferritin that from December 2024 until November 2025, it had increased to 11,000, but then again with increasing chelation that had come down to around 8,000. This is a growth chart. As you can see, from 13 years to 14 years till 15 years, there was a good growth, both weight and height, and then later on it became static.
So I'll start with Dr. Neeraj.
Yes.
Yeah, so with usually our focus is on LV function. How should we evaluate for when? What are the symptoms of pulmonary hypertension in patients with thalassemia, and how should we evaluate for them?
So one thing I will tell you, is in thalassemia patient, symptoms are difficult to assess for pulmonary hypertension, for LVD failure. I have been failure actually in those identifying a patient by clinically. So they always have liver, they always have spleen, they are slightly symptomatic. So difficult to
Your voice is breaking, Dr.
evaluate these patients. Best policy would be annual marker to assess pulmonary hypertension. Easy marker, a strong marker to assess pulmonary hypertension. Pulmonary hypertension is easy by echocardiography. You can suspect a pulmonary hypertension by echocardiography easily.
Okay. So I missed a little part of it, but yes. So, and Dr. Anuj, what are the echo parameters that you look for, and and other investigation that you would evaluate in a patient with pulmonary hypertension?
So the echo parameter that should be looked in case of pulmonary hypertension are the most commonly which everyone looked is the tricuspid regurgitation velocities. And if it is more than 3.3 to 3.2, then it is a significant. It suggests a pulmonary hypertension. Other is a pulmonary regurgitation jet velocity, which we also should look for. And if it is more than 2.5, it suggests and it correlates with a mean pulmonary artery pressure. So it is a better marker of pulmonary hypertension. And then we should look for the interventricular septum position. Generally in pulmonary hypertension, they are D-shaped and they are bowing into the LV. And also the RA-RV are generally dilated. So all these echo parameters should be looked into. Also, some biochemical parameter marker which can look into is NT-proBNP, which generally correlate with the functional class of the patients. So generally, all these parameters should be looked into.
Thank you. So how would you treat, what are the current recommendations for treating pulmonary hypertension? Is it different in thalassemia group compared to any other group of patients? Dr. Neeraj?
So pulmonary hypertension is multifactorial in thalassemia. Like in heart disease, had different etiology. So multiple groups have been devised to classify pulmonary hypertension, and thalassemia comes into multifactorial etiology. That's why all therapies which work for other condition may not work for this condition. That we have to understand. But we are left with same drugs which we have for other patients. We don't have a separate drugs for them. So we have sildenafil, we have bosentan, we have prostacyclin, like heliopros we use. These three groups of drugs we have to treat these patients. Now, most of the times, pulmonary hypertension in transfusion-dependent thalassemia is you don't know what is happening. So rule out LV, like Dr. Sir has left now, he decided LV restrictive physiology. If you're talking about diastolic dimension restrictive physiology, treat that case. I think that is the most common cause of pulmonary hypertension thalassemia, which we see in our practice. Restrictive cardiac physiology. In those cases, when the heart failure, manage with SG2 inhibitors, manage with diuretics rather than pulmonary hypertensive drugs. But yes, if you are sure that these are not there, patient doesn't have diastolic failure, patient doesn't have elevated restrictive physiology, then you talk about sildenafil and bosentan. In practice, Anuj can agree with us, tadalafil and ambrisentan, there are two drugs which are commonly used. Normally, we use a single drug if it's mild pH, and if it's progressing, we go to the second addition of drug. Iliopros is also available for if there are pediatricians around. Iliopros inhalation is available, which is reserved for severe cases, acute cases. So that can be used in emergency till you are waiting for the chelation to help you.
So my next
And
question.
one thing, ma'am, I want to add, ma'am, and
I think Dr. Neeraj, your audio is breaking. So yes, Dr. Anuj, please continue.
So one thing is in this patient also, when the first time he presented to me, there was the signs of pulmonary hypertension, and he has
very poor in between.
And she has a low HB, and there was also hepatitis C positive, I think. So I think those parameters should all should be corrected, and low HB is also one of the one of the etiologies for pulmonary hypertension, thalassemia. So if we correct the HB part also, like in this patient, the pulmonary pressures can come down. So in this case, we were able to stop the sildenafil also. For last 6 to 8 months, she is off pulmonary vasodilator.
Yeah.
Normally, most of the times, pH will resolve with chelation, not with drugs. Chelation, intensify chelation, correction of anemia, as you rightly said, they will work. And drugs are only supportive. They are not treating the patient of pH. That's my belief. So scientific data, as you understand, primary etiology has to be corrected. So if you're talking about primary etiology correction like chelation, intensify, anemia correction, they would help better than the drugs. So most of the times, like I saw a patient today also in the morning, 40-year-old, mild pH. This is diastolic dysfunction. Child has a diastolic dysfunction, 40-year-old. Now, poorly controlled chelation therapy, ferritin high, MRI never done. MRI never done. So we know this is diastolic dysfunction. And in those cases, I have started with him diuretics and SGLT2 inhibitor rather than sildenafil. So yeah, as Anuj rightly says, treat the etiology. Find the cause and treat the etiology.
Yeah. So in this child also, the transfusion, I think that just by increasing the trigger of transfusion from like 7 or so to just bringing it up to 9.5 to 10 has actually helped us in this patient. So, so I think that was the next question for Dr. Farmakis. So I'll just briefly mention that this is one of those conditions where you increase the transfusion trigger to even higher than 10. And many a times, if it's in a non-transfusion dependent scenario that we are encountering this becomes an indication for shifting them into a transfusion dependent state, because till the time at least the cardiac issues resolve completely. So so there is no point of keeping them anemic after this, because it's just going to worsen the pulmonary hypertension. So, Dr. Anuj, is there any before overt LV dysfunction sets in such a patient, is there any role of early ACE inhibitors or beta blockers in this condition?
No, ma'am. Actually, even when there is a early marker like GLS is low, there's no role actually till the overt the LV dysfunction sets in, or the patient becomes symptomatic, or there is some biochemical marker like and NT-proBNP is raised. Till that point, there is no role of heart failure medications. Actually, there is no good outcome after earlier starting of these drugs.
Okay. And I think there's something which has been alluded to earlier also, Dr. Neeraj, that everyone wants to know what is I think there are two questions in this case as well as the next regarding activity and sports that are safe in patients with pulmonary hypertension. Dr. Neeraj?
Ma'am, in both, if pH is mild only, I would not limit the activity. I would not. If it's severe pH, then this patient cannot do all the activities. He has to do only routine work. So if you're talking about degree of pH has to be seen. Mild pH, I feel there is no restriction. The guidelines say there's no restriction for mild PH. But if you're talking moderate to severe PH, you have to limit to the routine work. And that same applies to the dysfunction, LV dysfunction also. Mild LV dysfunction, you may not restrict the much activities except the heavy exercise. Only the heavy exercise should be limited. But if you have severe dysfunction, you should not do beyond routine work. So, Anuj, do you want to add something here? Like, I could not find guidelines for this.
Rightly said, sir. So, if the patient has class 4 symptoms, so exercise should not be advised. Only normal routine activity should be advised. If the patient has like class 1, they have episodes of syncope, or there's a symptoms at rest. So obviously exercise can't be advised. Also, if there is a baseline saturation of less than 92%, in those patients also the exercise also not advised. Otherwise, till the class if the patient is class 2 or class 3, then light to moderate intensity exercise can be done.
Yes, actually, I remember one thing. You know, if that child has a pedal edema, we tell them not to do any exercise. That is a very easy guidelines in our system. If you have pedal edema, don't do any exercise. You have to do the routine work and do the therapy. So that is one point which we follow.
Lot of children now, no, they're actually very well transfused, and they do participate in sports as well as dance and such activities in school. So I just have a question, not related to this particularly. So like in many adolescent setting in the West, especially before sports, etc. Now there is an evaluation that has been recommended, right? So just to look for any arrhythmias and stuff like that. So is there anything like that recommended for a thalassemia patient?
So in older age group, I would add Holter in older age group, 40 years of age, but not in 25 years of age. So Anuj, please continue.
Yes, ma'am. So, if not in thalassemics, ma'am, but in heart failure per se, there are recommendation. So, before advising any exercise or sports participation, the under baseline cardiac evaluation should be done, and the clinical examination, ECG, echo, and apart from that, the important test or the investigation that can be done is cardiopulmonary exercise testing. So in that, they evaluate the functional class of the patient, and they also look for any exercise-induced arrhythmias or exercise-induced hemodynamic abnormality. And according to the functional class, they are prescribed the level of exercise which they can do. And if there is exercise-induced arrhythmias is there, or their exercise is doing hemodynamic abnormality is there, then they're not advised exercises, but the graded exercises can also be advised in those cases.
Okay, we'll come back to it in the next. Yeah, you please continue.
So, ma'am, in mild dysfunction or normal dysfunction patients, the normal activity or even the sports participation can be done, while in patient with severe cardiac dysfunction, which are symptomatic, which are asymptomatic and optimized on medication. In those patients, only low intensity exercise can be advised, but they should be asymptomatic.
Okay. So we'll quickly come to the next case, Dr. Sudipta, case number 3.
Yes, ma'am. So case number 3 is our last case. Patient of 12 years, male child, diagnosed with E beta thalassemia. So he was a non-transfusion dependent phenotype and did not respond to hydroxyurea and needed occasional PRBC transfusion. So his hemoglobin kept in the range of 4.6 to 6.1 and had received 3 PRBC transfusions and parenteral iron also when he was not diagnosed. And evaluated in March 2025 at our center, HPLC revealed that HbO2 was 67% with HbF of 16%, and he was having severe anemia with massive splenomegaly, but there was no distress or infection. So we had done an echocardiography at March 2025 which revealed a structurally normal heart with mild left ventricular dysfunction and LV strain. There was mild pulmonary hypertension, and there was PR with 23 millimeter mercury of gradient, and there was mild tricuspid and pulmonary regurgitation. No other anomaly was detected. So he was treated with folic acid and carvedilol and lacilactone, and we had increased the pre-RBC transfusion to keep the hemoglobin above 8 gram per deciliter. He was not started on chelation as serum ferritin, which recently was done. It showed 169 nanogram per ml, and he's being considered for luspatercept trial, but he is awaiting randomization at this point. So this is the growth chart. Both of the weight and height show that the graph is creeping below the third centile. As is okay. So thank you, ma'am.
So thank you, Dr. Sudipto, for presenting another very common scenario. The children with thalassemia, they often don't even get diagnosed even after 10 years also. So this is any typical patient who even had parenteral iron as management of anemia, but nobody's thought of sending an HPLC. So I'll come to the cardiology question per se. So in this scenario, like although he wasn't having any acute distress, he had some palpitations, and that's how we send him to you, Dr. Anuj. So what is the stepwise protocol for evaluating? So palpitation is a very common scenario in thalassemia settings because of anemia per se. They will tell you that there is some increased heartbeats in whenever they are running, especially or climbing stairs. So what should be a pragmatic view of as in evaluating these patients?
Yes. So, if any patient who presents with a palpitation, so there can be two differential to the palpitation in patients with thalassemia. One can be there can be any rhythm abnormality, or second can be this is because of the high cardiac output state. So, so we have to differentiate between these two. So, and if the palpitation occur at rest, it points to or it is associated with syncopal episode, dizziness. It points toward the rhythm part of the because of the arrhythmias. The palpitation may be because of the arrhythmia. Otherwise, if they are because of high cardiac output state, they generally don't tend to occur on the rest. And then on examination, if there is irregular heart rate or there is any feature of heart failure, so they can be differentiated accordingly. And on ECGs, we should look for the signs of if there is any rhythm abnormality, intervals are normal, whether there are any ectopics are there, atrial or ventricular ectopics are there, those should be looked into. If we are suspecting some rhythm abnormality, then we should also do a Holter examination for that kid also. And on echo, in high cardiac output state, we generally see the LALV dilatation is there, or if this high cardiac output state is for prolonged period, there can be mild dysfunction also. So this is how actually we should approach in case of palpitation.
Anything to add, Dr. Neeraj? Happy to see your video back on.
Yeah, ma'am. Actually, I reached home. So actually, again, I said, echo and Holter, you have to take a call whenever, normally ECG and echo goes together, and then Holter comes into picture most of the times in lot of setups. So if echo is normal, ECG is normal, symptoms are explained most of the time by ECG and echo, and otherwise you go for the Holter. So things are same actually.
So in non-transfusion dependent thalassemia, we are not really aggressively looking for a cardiac, as in like generally we'll talk about TDT after 10 years, you need a cardiac evaluation annually. Is there any similar recommendation for non-transfusion dependent states?
So in those cases, I would start early actually, because I want to start at 7 years or 8 years, depending on HB level. If it's going less than 8, then I would be worried about volume overload, such as high output failure, symptoms of high output failure, and LV diastolic volumes has to be seen. So in those cases, I would do early. Otherwise, in later age group, if you talk about later age group, like 10 years down the line, 15 years down the line, then, I would like to know for TRV, pH basically. I would be more worried about pulmonary hypertension and anemia because they are prone to have thrombosis, prothrombotic states. They have those things. So routine cardiac evaluation is advised in such cases also annually after 10 years again, mainly to see TRV. All adult patients, platinum-based patients, if you have high platelet counts, if you have iron overload situation, if you have history of thrombosis, I would like to see TRV in such cases. And if TRV is more than 3.2, I would like to see VQ scan and to rule out thrombosis and rule out anemia, iron overload also. Sometimes cath also comes into the picture when not found the cause of pH in such cases. So rarely we have done the cath also if I'm not able to find the cause of pH in such scenarios. So I would recommend annually after 10 years, either is transfer dependent, non-transfer dependent. I would go for both things, but some guidelines say if you don't have any pH, cardiac functions are normal, every 3 years follow-up is also advisable. So that can also be done. Minimum is 3 years follow-up if things are normal. But otherwise, annual would be a better choice in high-risk situations, especially in older age group and in splenectomized patients.
Yeah. So this was a question for Dr. Farmakis, whether you'd shift to a transfusion regimen. So for trainees in the group, this is again a scenario where we would want to shift to a scenario. And since there are now new drugs and he's awaiting randomization, that's the only reason why he is not on a transfusion regimen. But any other patient would actually be shifted to a regular transfusion regimen, even if it was NTDT earlier. And Dr. Anuj, I think we discussed this a little bit of it, but in a non-transfusion dependent scenario also, like where the hemoglobin is maintained around 7-8, families are actually quite happy that don't need to transfuse. But with this the other way around, their morbidity actually just piles up after they are like 8 to 10 years of age. So is there any specific recommendation for altitude, sports, etc. in this scenario?
So, ma'am, for high hydration, ma'am, they should be maintained a euvolumic state. Except in patient who have a class 4 symptoms or their advanced heart failure. In those patients only the fluid restriction or fluid intake restriction should be done. Or there is serum sodium level less than 130. In those cases, the fluid should be restricted. Otherwise, euvolumia should be maintained. And for sports, sports in case of heart failure, as we have already discussed, if they have normal function or mild dysfunction, so there is no restriction. They can even participate in some of the competitive sports also, but they should be asymptomatic. And if patient are asymptomatic and severe dysfunction but asymptomatic, well optimized on medication, they can do a low intensity sports. They can engage into low intensity sports, or but they are symptomatic, then obviously we cannot advise for regular sports participation, but mild exercises, graded exercise can be advised to them. Yes.
Can I make a comment here, Dr. Nita?
Yes, ma'am. Yes, ma'am.
So, Dr. Neeraj and Dr. Anuj, the general population of our thalassemia patients in our country, you are very, very well aware, that some of them are doing excellent, they are getting the best of the treatment. And in some places, they don't even have access to the good and safe blood transfusions. So as we understand that it has to be a combination of everything, all the medical aspects of the treatment, where is the maintain the hemoglobin and the chelation therapy, and then of course is the regular investigations and to have a good lifestyle. But the problem in our country is what we have seen, because we have worked at the grassroots level, is that when the children are small, their families below the age of 10, they're more focused on the blood transfusions only. So they want that the blood transfusion should be there and all that. They do not understand the importance of maintaining the good hemoglobin, because that is the basis of the treatment. So, and then, if they take even the chelation therapy and all that, and sometimes we find that they ignore the investigations. So I think we have got a mixed kind of a thalassemia population in our country. So in the end, I would like Dr. Nita, someone to give the back home message, for our thalassemia populations, for the thalassemia independent transfusions, that it has to be an ideal combination of everything. If you are looking like the future therapies like gene therapy and all that, to keep our children in the perfect of the health. So that's the comment. I hope that will be covered in the end, by one of you.
Yeah, so we are just waiting for Dr. Neeraj to join back. I think that was the last question for him as well.
I'm on, ma'am. I'm on. Yes.
So I think we will wind up this question and take up Madam Tuli's.
Can you hear me, ma'am? I am there. I am there. Can you hear me?
Yes, we can hear you. So
Okay,
that
ma'am. Okay.
question, Dr. Neeraj, regarding post-splenectomized patients. So they're at higher risk of pulmonary hypertension. So in those patients who have thrombocytosis, what is the recommendations for antiplatelet, anticoagulation in these patients?
So, it's easy. High-risk patients of pulmonary hypertension with splenectomy, annual follow-up is must. So you have to do annual follow-up and look for pH. And it's easy to pick up pH by echocardiographers. It's not a difficult job. Just look for the values, TRV more than 3.2. You're talking about pH. Now, role of anticoagulation, as we already know, they're prone to have thrombosis, they have thrombocytosis. Aspirin antiplatelet drug is to be used. So antiplatelet drug is used. Now, anticoagulants cannot be used. Mostly it's not required unless you have risk of you have atrial fibrillation or you have documented episodes of thromboembolism, either the lungs or the brain. Then you can think of anticoagulation like warfarin, estrom. Otherwise, aspirin alone is recommended and can be given easily and on daily basis for lifelong.
Thank you. I think with that, we come to the end of this panel, the questions that we had prepared. And there are many questions in the chat box. So we can take one by one and before the final comments that Madam had requested. So, so one question is regarding someone who is recovering from congestive heart failure. What is the chelation that is recommended? So I think I'll take that question. Like anybody on congestive cardiac failure because of iron overload and cardiomyopathy related to iron overload, yes, definitely an add-on agent, desferrioxamine, is recommended. And many a times if it is one of the indications for an emergent chelation. So then IV chelation would be indicated as a continuous infusion. We do it once in a while. Nowadays, it is less because if you are following them up from the beginning, the requirement for IV chelation for cardiac failure is actually less. Now, another question which has come up, Dr. Neeraj and Dr. Anuj, is do thalassemia patients with diabetes need to take any precautions when it comes to heart-related issues?
So yeah, lifestyle modification cannot be emphasized more than that. You take care of lifestyle because you're already prone to heart disease. You are already prone to iron overload. So a rest of factors you can control: smoking, alcohol, diet. You take care of exercise. That has to be taken care in all. So strict control of diabetic protocol, strict control of sugar is mandatory in such cases.
Yeah, extremely difficult also in that scenario. Any role of levosimendan?
Anuj, you want to? I don't know about levosimendan, why he's using it. Acutely, if you're talking about acute phase, acute heart failure, in thalassemia, BP is already low. You're already struggling with lower side of BP. In such cases, any drug which has potential to reduce the BP cannot be used. So levosimendan and milrinone are strict no in thalassemia patients because they're already on the lower side of BP. So avoid, if you're talking about acute heart failure, avoid excessive inotropy, accept the lower side of BP, intensify chelation, control arrhythmia, control electrolytes, look for cortisol levels, and that should suffice for the acute heart failure. And levosimendan may not be a good choice because it leads to vasodilatation.
Another question, I think it's regarding a patient, a 7-year-old girl with thalassemia. She has an ASD ostium secundum AST 6 mm left to right shunt. So is there any difference in transfusion that you would recommend in this scenario? I don't think so. What
Yeah,
would...
and you're right, ma'am. 6 mm, nothing. 6 mm is you forget about ASD and manage thalassemia.
Yeah. What is the cutoff for LVGLS?
So it should
yeah,
be
Anuj,
18,
please.
madam. It should be 18, minus 18. It should be less than minus 18. Anything more than minus 16 is abnormal.
So, Dr. Nita, I was involved with some study in Rajiv Gandhi University, Rajiv Gandhi Hospital for leukemia patient. I'm looking for strain levels. So he's right, minus 18 for adults, or anything which is beyond 10 years or 15 years, or I think 15 years, it will become minus 18. But children levels are different. But as we are talking about thalassemia, where we're talking about more than 15 years of age, so most of the times the levels will be same at minus 18 for LV. Should be okay.
Okay. Another question, if an adolescent boy has recurrent narrow QT tachycardia, supraventricular origin with severe cardiac iron overload, what are the other treatment options other than chelation intensification?
Dr. Anuj, please take the question, please.
So any supraventricular tachycardia should be tried to should be reverted by adenosine or by if the patient is hemodynamically unstable, then defibrillation can be tried, or then other anti-arrhythmics like amiodarone, beta blocker, those can also be tried if it is not reverted by these two things.
Another patient, I think it's a patient who was asked regarding, probably should be thalassemia patient who is moderate AV stenosis. And what are the potential risk factors that should be kept in mind? And what is the role of DEPA turn?
Moderate
AV stenosis.
means aortic valve, maybe aortic valve stenosis, Anuj, hai na?
Yeah.
Okay. So
maybe he's talking about aortic stenosis. Aortic stenosis.
So it depends what is the severity of the stenosis. If it is severe enough, then it has to be addressed, regardless of the thalassemia, non-thalassemia. If it is severe aortic stenosis, then the appropriate treatment should be done.
Yes. And if it's moderate, just keep following with the cardiologist every 6 months or 1 year. Please keep following this. These kids can be totally asymptomatic till they become severe stenosis. So don't forget that this is a disease. You have to follow this patient regularly with the cardiologist.
Thank you. And I think last two questions. One is for Tuli ma'am. Is there a help desk where we can send reports and get expert advice? I think you can send it to Mrs. Tuli, Thalassemics India. They'll connect with the experts and.
I think, Dr. Nita, we have to, after this webinar, we have to really think about that, that we have to have some helpline and think of a help desk, which is a very good suggestion, made from Pune, has come from one of the patients. And we will think about that, and we will certainly, meanwhile, till we establish such kind of facilities, you can always send it to us, and we have a scientific advisors group committee, and we will forward your queries to them. Thank you.
Yeah, and I think I'll take this as a last question, Mrs. Tuli's question on what can we do as in for patients. Ma'am, do you want to repeat the question? Dr. Neeraj has joined.
Well, my concern was that, as we all know, the ones who are here, and this is for the ones who are not here, for our patients and the parents, we always teach them that, well, you have to maintain a good hemoglobin, which has been recommended as per the TIF guidelines, as per the IAP guidelines, as per your doctor expert advice, and all that combination, in having combination of good chelation therapy, and keep yourself busy, do sports and all that, lifestyle changes and all that, and also to get the regular investigations done. What normally happens is, as you all are aware who are from India here, that, well, health is not it's not the same everywhere. In some of the centers and in the cities, it is the best of the facilities that I see. And I feel very, really proud when I meet those patients. They do not look thalassemic at all. They are doing very well, and some of them are really, now they have reached, crossed the age of 50 years also. I know one of the patients who's 58 years old now. They are married, they have the children. But at the same time, the fact is that majority of our patients, as you had heard Dr. Dimitri saying, that globally also 60% of the patients are not receiving, they do not have access to the best of the healthcare as far as thalassemia is concerned. So in our country, I do not know, according to me, as my experience, I feel that we must be having 80% of the patients who do not have access to the proper treatment as per the guidelines, So in those scenarios, when we teach them that, well, have a good transfusion, maintain your hemoglobin, get the proper chelation done, and be active and get a good, good food and all that, get the regular investigations, but that is not happening in our country. It is just being followed by a very handful of the families, patients who have access to such kind of medical care. So what do you, as an experts, what message that you want to give to our, one is that what the carry back message for all the who are delegates are here, so that they can pass it on to the thalassemia patients, or what do you suggest to even to the community leaders, that how, and together with the medical,
अरे पगल्या काही करते का मूर्ख तिथे ऑनलाईन सुरू आहे मूर्ख
improve upon the conditions in our country, so that we also, when we go abroad and all that, our patients are not looked upon like coming from a developing with a short stature and all that. So these are my concerns, which have been there for many, many years. And since we are specially talking about this topic today in a separate webinar, so I would request your expert advice on this.
Dr. Neeraj.
So, ma'am has said a lot of words, and it's difficult for a developing country to follow with a huge load. I have learned few things, ma'am. As I joined Gangaram in 11. I got involved with thalassemia. But what I understood is a family should not have two thalassemia kids. If you have one thalassemia kid, if the child is getting, your family is getting second thalassemia kid, it should be prevented. One thing I've learned. Second thing, group together the investigation. When the child is coming for blood transfusion, do all the investigation so that his time is not wasted. We have to understand it's a chronic state. They will keep coming to you again and again. So minimize the visits to the hospital. So everyone should be under one roof. If you're coming for blood transfusion, everything should be done in that scenario. You should not be coming for echo separately, ECG separately. That should be done in that scenario only. That would improve the quality of work. I think that would help every kid. Then third thing would be reduce the cost of investigation in a private setup. Government setups are overloaded. Reduce the cost of investigation in a private setup for thalassemia. Like we have done echocardiography for thalassemia separate billing, 1,000 rupees compared to a 3,000 billing. I understand this is also costly, but if you're coming to a government setup, reduce the cost of investigation, which are not, because they're coming regularly to you. So thalassemics should have a separate billing counter in a private setup and more accessibility to the things. So I again say, this is my knowledge over the years, reduce the visits, keep them less waiting time. If they come in the morning, they should be relieved by evening. Try to use them on Sundays. If that is feasible, that can be helpful to the kids.
Dr. Anuj?
Yes, madam. I think the holistic view should be taken for any thalassemia. One medical, the treatment part is one thing. The maintaining the quality of life for that kid is the other part. So so whenever they visit the hospital, they should be counseled appropriately, and that visit should be that visit should be utilized for every aspect of that kid, whether for nutrition, for the cardiology part, gastro part, or of the counseling per se. That visit should be utilized for the maximum, actually. This is what.
Thank you. So I think we'll wind up today's session with that. And I would like to thank all the speakers for their insightful presentations and to all the participants for active engagement. And we hope today's session, this is our 6th in the series of advanced thalassemia webinars. We hope today's session helps strengthen all our efforts to diagnose cardiac complications early, as well as to treat them properly and improve long-term outcomes for individuals with thalassemia. So we look forward to all of your participation in the future sessions. And the next session will be next month. We'll be releasing the brochure soon. I would like to thank all speakers. I would like to thank Thalassemia International Federation. And I would also like to thank Mrs. Tuli, who is the backbone behind these sessions, for staying throughout the program and for her valuable guidance. Thank you, everybody.
Thank you.
Thank you.
Thank you. Thank you.